Whether or not you plan on specializing in psychiatry following graduation, it's important to really take note of these lessons as mental health transcends all specialties. As a board-certified family nurse practitioner practicing in obstetrics and gynecology, my experience with psychiatric disorders is really centered around depression and anxiety in the postpartum stage. This is exactly why we collaborated with psychiatric nurse practitioners nationwide to include the most pertinent information right here in these videos and in our specialty notebook. Let's get started. Developmental theories and mental health throughout the lifespan. The mental health continuum is the spectrum of mental wellness from thriving to severe mental illness. We may identify ourselves at different points on this continuum at various stages in our life. The World Health Organization defines mental health as a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community. A variety of factors can influence our mental health. There are 5 general theories to explain the development of psychiatric disorders: genetics, epigenetics, infectious disease, traumatic brain injury, and environmental exposure. So as you can see, the cause of psychiatric illness can be multifactorial. It can also affect people at all stages in life. Let's think about pregnancy for a second. Pregnancy can be a highly stressful event for women, even with adequate support systems in place. Anxiety and depression may be at the forefront due to the tremendous event that childbirth presents. As the nurse practitioner, you would promote maternal health with education on nutrition, ways to reduce stress, childbirth education, and partner support. As we move out of pregnancy and into childhood, the statistics can be quite startling. About 1 in 5 children under the age of 18 have a diagnosable psychiatric disorder. The stigma surrounding mental illness in adolescence is deafening and often a gateway for those afflicted to abuse alcohol and illicit drugs. The role of the pediatric nurse practitioner is critical in identifying risk factors and signs of psychiatric disorders. Approximately 18% of the geriatric population has a psychiatric disorder, with depression and anxiety being at the forefront. We often find patients in this age group feeling unheard and brushed off. Remember, frequent mental distress is not considered a normal part of aging and can affect a patient's overall health. As a nurse practitioner, taking the time to genuinely listen to their concerns can be the change that is needed in treating mental health ailments in the geriatric population. Understanding how psychiatric illnesses are caused and how they can be present across the lifespan can help you, as a provider, be the first to recognize the signs and better treat your patients, no matter what field you specialize in. As nurse practitioners, we are constantly assessing our environment for safety and red flags, whether consciously or unconsciously. This may not be the case with a patient with a psychiatric disorder who is unable to regulate their nervous system and instead responds to every stimulus as a potential threat. This is exactly why it is essential to respond to the patient in a way that promotes a safe environment. The environment can greatly impact the development, identification, and treatment of mental illness and psychiatric disorders. Here's how to set the stage for a safe environment when treating a psychiatric patient. First, you need to scan the space. This means that you ensure that the space is safe before the patient enters it. Second, assess for distress. To do this, you will begin by observing the patient for signs of distress. The mini mental status exam is a great tool to assess the patient's mental status. Third, create a connection. As with most patient-provider relationships, and especially in the case of caring for the psychiatric patient, trust needs to be established before treatment can effectively take place. Consider that the patient may have a history of trauma and be wary of new interactions as well. Finally, prepare a plan. You've set the stage and now treatment can begin successfully. Confidentiality is key in all aspects of healthcare, especially as it pertains to mental health issues. With that being said, the occasion may arise when it is critical to report certain behavior for the safety of the patient or others. It's important to be knowledgeable regarding laws in your state of practice. It may take time to lay the foundation for a safe environment and trusting relationship, but it is an essential part of treating the psychiatric patient. The Psychiatric Review of Systems begins with a basic medical review of systems, including various body systems as you would in general practice. This acts as a segue into the Psychiatric Review of Systems using the mnemonic, depressed patients seem anxious, so claim psychiatrist. D stands for depression and other mood disorders like major depression and bipolar disorder. P stands for personality disorders, such as borderline personality disorder. S is for substance abuse disorders. A stands for anxiety disorders like panic disorder with agoraphobia and obsessive compulsive disorder. S is for somatization disorder and eating disorders. C stands for cognitive disorders like dementia and delirium. Finally, P is for psychotic disorders like schizophrenia, delusional disorder, and psychosis accompanying depression, substance abuse, or dementia. A more detailed review of symptoms can be performed based on the suspected or confirmed diagnosis. The tool of assumption can also be helpful in eliciting more detailed information into how the patient is feeling. For example, you could say, due to the increased stress you're experiencing, I would understand if you're feeling a little more anxious than usual. This leads to feelings of rapport and comes from a place of non-judgment, allowing the patient to express their symptoms in greater detail. An essential tool utilized by the psychiatric nurse practitioner is the DSM-5 reference book. The DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders created by the American Psychiatric Association, or APA, to assist providers in diagnosing mental disorders according to standard criteria. It was first published in 1952, and the most recent revised edition, or 5th edition, was released in 2022. It outlines diagnostic criteria with signs and symptoms of a multitude of psychiatric disorders. Obtaining a proper medical history cannot be emphasized enough. Many metabolic, respiratory, and neurological conditions can have shared symptoms with psychiatric disorders. Failure to properly obtain a patient history can impact the diagnosis and ultimately delay patient treatment. Shared symptoms of metabolic and psychiatric disorders may include social withdrawal, weight gain, depression, personality changes, anxiety, fatigue, and inability to concentrate. Examples of metabolic disorders with shared symptoms include diabetes, thyroid disorders, and Cushing syndrome. Let's move on to respiratory disorders with psychiatric symptoms now. Respiratory distress caused by various disease processes can trigger anxiety and panic attacks. Respiratory and psychiatric disorders may share symptoms of social withdrawal, confusion, agitation, restlessness, seizures, personality changes, anxiety, fatigue, inability to concentrate, hallucinations, and even delirium. Examples of respiratory disorders that can have shared psychiatric symptoms are carbon monoxide poisoning, hypoxia, sleep apnea, and COPD, which includes asthma and chronic bronchitis. Now that we've explored metabolic and respiratory disorders, let's take a look into neurological disorders that may be mistaken for psychiatric disorders. Assessment of the ADLs and administration of the mini mental exam can really help to rule out neurological disorders. Shared symptoms may include numbness, tingling, headaches, depression, changes in personality, confusion, inappropriate affect, dementia, memory loss, and changes in gait. Patients with neurological disorders like traumatic brain injury or TBI, epilepsy, multiple sclerosis, and myasthenia gravis may experience any of these symptoms. In each of these cases, a full neurological workup is needed. As you can see, a full history is needed in order to properly diagnose a patient and develop the appropriate plan of care. Major depressive disorder is characterized by persistent, often daily, low mood and decreased interest. The mnemonic M, S, I, G, E, C, A, P, S can be used to obtain the review of symptoms. Risk factors for MDD include lack of close relationships or history of divorce or separation, childhood trauma, first-degree relatives with a history of depression, and comorbidity with conditions like diabetes, obesity, and cardiovascular disease. The DSM-5 diagnostic criteria are as follows. 1. At least 5 out of 9 symptoms are present in 2 weeks with a change in previous functioning, and one of the symptoms must be depressed mood or anhedonia. 2. Symptoms cause impaired functioning. 3. Symptoms are not the result of a medication or substance other than the medical condition. 4. The depressive episode is not a result of a schizophrenic type disorder. And 5. There is no evidence of a hypomanic or manic episode. Medical management of major depressive disorder includes a variety of medication classes that can be found in detail in our specialty notebook. However, SSRIs like Lexapro and Paxil, TCAs like amitriptyline, and SNRIs like Effexor XR are options that have been found to be more efficacious and well tolerated by patients. Alternative treatment options are available and may be used exclusively or as an adjunct to prescription medication. Prescription strength vitamins like L-methylfolate and OTC supplements like St. John's wort and SAMe have the potential to improve patient symptoms. Psychotherapy can also help the patient change behaviors and thoughts through skill acquisition and insight. In severe and treatment-resistant cases of depression, hospital-based interventions like vagus nerve stimulation and electroconvulsive therapy may be considered. Major depressive disorder is one of the most common psychiatric conditions and seen in all specialties in some form. It is our responsibility as nurse practitioners to recognize these symptoms, treat, and refer as appropriate. In this lesson, we are going to discuss anxiety disorders, which affect 6.8 million adults nationally. Anxiety disorders are characterized by feelings of fear and anxiety that affect a person's ability to function daily and often cause somatic symptoms. Patients with generalized anxiety disorder are unable to mitigate stress responses and are suffering from emotional dysfunction. Those with anxiety often have comorbid major depressive disorder. Symptoms of anxiety disorder include sweating, chest pain, shortness of breath, trembling or shaking, palpitations, fear of dying, chills or numbness of the extremities, and insomnia. Risk factors for anxiety disorder include a family history of anxiety disorders, a personal history of stressful life events, and the female gender. As statistics show, women suffer from anxiety more than men. There are 5 types of anxiety disorders: specific phobia, social anxiety disorder, generalized anxiety disorder, panic disorder, and postpartum anxiety. Treatment options for anxiety disorder are numerous and include a variety of medications in the following classes: benzodiazepines, beta blockers, dopamine reuptake blockers, MAOIs, anticonvulsants, tricyclic antidepressants, SNRIs, and SSRIs. Psychotherapy can also help the patient change behaviors and thoughts through skill acquisition and insight. It is crucial to treat the anxious patient with respect and empathy while reducing environmental stimuli. Question 1. A 59-year-old female presents to your office with complaints of severe fatigue, waking up in the middle of the night, inability to concentrate, and increased appetite for 1 month. She has a history of type 2 diabetes, well controlled with oral medication. Her vital signs are stable and her most recent hemoglobin A1C was 5.9%. On further questioning, the patient is undergoing a separation from her spouse and she was recently laid off from her job of 15 years. She verbalizes that she wants to go out with friends, but just doesn't feel like bothering with it all anymore. Given this information, what is the most likely diagnosis for this patient? Correct. The answer is C, major depressive disorder. Risk factors like separation from her partner, female gender, and comorbidity with diabetes are present. Additionally, her symptoms meet the DSM-5 criteria for major depressive disorder. Question 2. A 29-year-old female presents to your clinic in Miami wearing a large sweater with complaints of fatigue, depressed mood, 15-pound weight gain, and the inability to concentrate at her job as an insurance agent. She denies any changes to her social history, changes in her diet, or activity level. She is married, lives with her spouse, and has been at her current job for 6 years now. She does note some increased stress as she has initiated college courses recently. She is not aware of any pertinent family history. She continues to express that this is not normal and she has no history of prior depression. What is your next step in the patient's plan of care? Right, option B is the best course of action at this time. As many metabolic disorders can mimic psychiatric symptoms, this patient seems to exhibit similar symptoms to that of hypothyroidism, and hence a workup should be done to exclude this cause. Question 3. You review your clinical schedule for the day and are pleased to see that a familiar obstetric patient is scheduled with you for her initial postpartum visit after having her baby 4 weeks ago. As you recall, her pregnancy was uncomplicated and planned by her and her spouse, both of whom were very excited to expand their family. The patient arrives for her appointment with her spouse and infant. You immediately notice that she is trembling, clenching her hands together, and bouncing her foot up and down repetitively. Her spouse expresses concerns that there has been a shift in her personality, and although he has attempted to help with the baby, she will not let him or anyone else care for the child alone. The patient chalks it up to lack of sleep, but admits that she does have an intermittent shortness of breath and chest pain, especially when she thinks of scenarios that could harm her newborn baby. She is exclusively breastfeeding. What is your diagnosis and plan of care? Right, option C is the most likely diagnosis with the appropriate plan of care. Although postpartum depression and anxiety may occur simultaneously, alprazolam is not the best treatment option, especially given that the mother is breastfeeding. That's it, guys. I'm so happy you were able to join me today, and I hope you were able to really process this critical information. Remember, we have all been where you are at some point in time. Don't lose sight of your goals, and you will succeed. Don't forget to check out NPHub.com to get access to all of our specialty notebooks. Reviewing these notebooks before and during your rotation will help you lay the foundation for a rewarding learning experience and maybe even a potential job offer down the road. Good luck.